Welcome, everyone. I'm Dick Deming. I'm Medical Director of Mercy One Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. And our topic tonight is the emergency room. And our guest is Dr. Hinio Carrion. Welcome, Hinio.
Hey, good evening, Dick. Thank you so much for having me on your show. I'm excited to be here and see what I can learn and what maybe I can share with you is what's going on in the emergency department.
Yeah, so Hinio is a longtime emergency room physician, and currently he is the chief medical officer for all of Mercy One for the state. But I know that's not exactly your title. I think it's like vice president of medical.
So chief medical executive is
Chief
currently
medical executive.
the title, and I have been an emergency department physician for 17 years now. So I've been blessed to have the opportunity to work within Mercy One, our Des Moines campus, West Des Moines campus. So continue to see that grow and be a part of that group. So it's been great.
17 years of experience as an emergency physician. And the reason I wanted to have you as a guest for this cancer education series is I would say at least half of cancer patients have some journey through the emergency room, the emergency department, somewhere along their journey, either related to their cancer symptoms or related to side effects or toxicities of cancer treatment. So, but before we talk about that, we're going to get to know you first. So where did you grow up? Where did you go to high school?
All right. I went to high school in LaSalle, Peru, Illinois. So grew out about 2 hours west of Chicago.
So LaSalle, Peru, are those two towns?
Correct. And it was kind of a commuter school, so more of a rural community. So if you know rural communities, we're commuting a ton of kids from surrounding communities to make that school. So I want to say there was about 10 different communities that were filtering into the school that made it kind of a relatively large just because of that.
And how far from Chicago?
About 2 hours west.
Okay. And what was your claim to fame in high school?
I was a class clown.
Oh, really?
Yeah.
All right.
Yeah. So
did you also perform like in theater or music?
No, I would definitely say I would not be one of those individuals that were considered a performer, if you will, or that your professors would want you to be a performer.
More of a practical joker.
Yes, I would tend to say that.
And when you graduated from high school, where did you go next?
So I then came to Drake University. So Des Moines, Iowa, where I was blessed to meet my wife. So and still married. We just had our 24th wedding anniversary a little over a couple weeks ago.
Congratulations.
Yeah.
And how did you choose Drake?
It was one of the smaller schools. I was actually set on going to the University of Michigan. At the time, the Wolverines were pretty popular. We had the Fab Five. Football was pretty immaculate. So a Big Ten school. That's where I was looking. I actually looked at University of Iowa, University of Illinois, University of Michigan. So I was really favoring the Big Ten. So it was the only private school that I was looking at. And actually, my sister, older sister, sat me down and said, maybe I was too immature to go to a Big Ten school. And so I took those words to heart, evaluated critically my selection process, and opted to come to Drake for the smaller environment that they provided, but yet kind of a very high education.
Right. And obviously you didn't even quite realize what a fork in the road that was and how that changed your life trajectory.
Agreed. Had no idea that I would consider myself an Iowan at that time. So came to Des Moines in 1995, and outside of a couple years of residency education, have really been blessed to essentially grow up in Iowa.
So when you started Drake, what was your first major?
I was a bio major. So was pre-med right from the outset, knew I wanted to be a physician. So curriculum was kind of all based on that.
Okay. And then when you graduate from Drake? Where did
I
you go?
attended Des Moines University,
Okay.
so was blessed to graduate from there. So my wife had a little bit of a different trajectory. She had started business, transitioned to bio, and then went to nursing at Grandview. So when we were kind of deciding kind of next steps and what our future looked like, there was a big decision: is do you go to medical school somewhere else? Do you stay close? She was going to finish kind of similarly around the same time that I would finish my clinical work at Des Moines University. So made the decision that I would stay in Des Moines and allow her to finish her undergraduate degree at Grandview. So she graduated with nursing, and then I graduated from DMU.
And then what was the process of deciding that it was the emergency department that you wanted to focus on?
So I started working at Mercy One in 1998. So started as a patient care tech, actually on ortho. I thought I wanted to do orthopedics.
And was that why you were an undergrad?
I was an undergrad. So I was a
Great.
junior in undergrad. And so started to get a little bit of exposure, realized that in the emergency department as a patient care tech, you had some autonomy. You learned how to draw blood, you learned how to do EKGs, you learned how to do some casting. So I thought from a growth and development perspective, that would be a good opportunity for me. Never did I realize that I would fall in love with kind of the flow, the patient acuity, the different illnesses that you would see. And so the clinicians were very warm and welcoming. The environment was what I call controlled chaos, if you will. And I loved it. And so when I went on to do my rotations, I told myself, you're going to feel like emergency medicine is where you want to go because that's what you're comfortable with. So look at every other specialty, ask yourself, is this what you want to do with the rest of your life? And I approached every rotation in that same capacity. And as I critically evaluated what I enjoyed from each experience, it was the acuity, the patient contact. And so at the end, emergency medicine was where my heart was, and that's what I opted to do.
And then tell us about the training to become an emergency department physician.
So originally, I actually went to St. Barnabas in New York, did my internship there. We thought maybe New York would be a great place, and we had our first baby in New York. And as some of you may know, the cost of living in New York for a resident isn't ideal, and we were paying a pretty significant premium for a one-bedroom. Our family was in the Midwest. And although the training was magnificent, our attending physicians were great. The pathology was bar none. And for some of you who may or may not know, they were unionized where we were, and union nurses at the time were very restricted on what they did. So you as a resident did a lot of the clinical care. So it was a very different environment that I kind of grew up in. But I feel like it definitely added to my clinical experience. But after a year, we made a difficult decision to leave. Obviously, my dad also had become more critically ill. So we opted to kind of return to the Midwest and kind of completed my residency at the University of Illinois Chicago at St. Francis.
Okay. And then the trip back to Des Moines, how did that come about?
We were, so unfortunately, my father-in-law passed away in 2006. My wife had actually relocated to Ankeny to be with him. He had died of metastatic bladder cancer at the time, and he was 46 years old. So a really young individual, and that was very hard on her family. And we made the decision at the time that to be there for her mom, continue to be supportive, that we would come back to Des Moines once we graduated. And at the time when we were making the decision, he had not yet passed, and then subsequently he died in November of 2006, and then graduated in 2007, and we started August of 2007 here.
Okay. And you also mentioned that your father was ill, and your father also had stage 4 cancer.
Correct. Prostate cancer as well. And he actually had passed in 2005 of that time frame. So
a lot of loss in that short period of time.
Yeah.
Yeah. So as a physician, and then being your father dying and your father-in-law dying, and were you the only doc in the extended family?
And that for sure. And there was a lot, again, as a medical student when my father got diagnosed, and then as a resident when my father-in-law was diagnosed, you were looped into a lot of those discussions and being asked. And as you know, as an emergency department physician, you may know certain elements of malignancy treatment therapies, but pretty superficial, unlike oncologists that are specialized in this field. So you're asking a lot of questions, right? As far as the treatments, therapies, things that you would be needing to be aware of as far as side effects and what other options. But to your point, very much looped in to those conversations. And it was a very interesting journey, just kind of speaking of my father-in-law, because he actually, his main symptom was fatigue. And that was really his only manifestation of illness. And not until his illness progressed was he developing urinary retention and those other symptoms. And so originally it was looked at more as a maybe major depression type of symptom. And then it wasn't until the fatigue became more profound that we finally opted to take him to the Mayo and was diagnosed there within 24 hours of therapy and started to have actually pretty significant pain probably a week after we had determined the diagnosis. But as you can imagine, and this is why I always encourage individuals to have very close ties with their primary clinicians where they live, is from experience, getting narcotic pain medications to control his pain became challenging because he didn't have a primary care physician per se that knew of his diagnosis. And so that created a lot of roadblocks for him to get the therapy, and then actually required him to go to the emergency department to seek care and get appropriately treated, which is one of the realities of what we do in the emergency department, and see those type of patients with some degree of frequency of those that either have refractory pain or potentially even new diagnosed cancer because of the pain that they're feeling.
So I have a question for you. Before I do that, I just want to share with you that a generation before your father-in-law, my mom was diagnosed with some mental health issue that turned out to be stage 4 cancer and a brain metastasis. And this was in South Dakota in the 60s. And it was a trip to Mayo where, we didn't even have brain scans in South Dakota there, but it's just kind of ironic that,
Similar journey.
Similar journey. How would you say that your father's cancer journey and your father-in-law's cancer journey, how do you think, looking back, that those journeys may have affected you in how you are as a physician?
I definitely think from a compassionate side, understanding, it has added tremendous amount to that element of my approach to patient care. I think understanding why individuals are in the emergency department, and at times maybe they've experienced someone with a loss, with a cancer, and they just need the reassurance that they themselves are fine, that yes, your relative can have this malignancy or have this issue. It doesn't necessarily mean the symptoms that you're feeling are related to a malignancy. On the other side, for those individuals that are going or experiencing their cancer journey, that you are empathetic to the situation that they're experiencing, whether it's related to pain or just fear associated to a side effect or a new medication that they've started, and in either attempting to provide reassurance or confirm a concern that they may be having. So I think for me personally, I feel I take that to every patient encounter, not specific to those with cancer. Now, I always, I think, will have a deep passion for the work that you do philanthropically, because I think we all envision a day or a time where cancer can be eliminated, where we're looking at it for therapies of proactively managing and decreasing individuals' risk of cancer.
Yeah. Let's shift now to talk about the emergency room, emergency department. So I've used both phrases. Which is preferred nowadays? I mean, we call it the ED, but that also means something else in medical terms. So, and those of us grew up with television, it was, the emergency room. So the ER.
Yes.
But when did it shift from calling it the ER to calling it the ED?
So I want to say that was something that's always looming in the back, but I want to say somewhere around 2010, there really was a bigger push to say we are a department of the hospital and should be called emergency
Yes.
department.
We're
and
much
we're
more
not-
than a room.
Exactly. We are not a room. Now,
An,
the challenge
an
was
operating room is a
overcoming
room.
the show ER
Yeah, right.
was the bigger obstacle. So
Yes. So now, so it's officially the emergency department, and the residency is called emergency medicine. Is that the residency?
correct.
Yeah. So you're an emergency medicine physician.
Correct.
Yeah, and you work in an ED. So tell us.
And that's a good point that you bring up, because historically, so if individuals remember back prior to 1980, so emergency medicine as a specialty is actually a relatively newer specialty. So prior to the 1980s, it was essentially anybody who wanted to pick up an extra shift to work in the emergency department. So if you were a dermatologist, if you were an orthopedist,
you could even be a radiation oncology resident and moonlight in an
ED.
in the ED.
So there,
It was
there
an
is-
ER then.
and it probably was a room at the
Yeah.
time. And there are still a lot of individuals that I will be asked when working clinically and say, when are you going to become a real physician, or when will you start seeing patients outside of here? How much more time in your training do you have? Because individuals may perceive emergency medicine as kind of your training or your stepping stone, and not necessarily as your career, which again has evolved over the last 40 years. But again, 40 years is not that long ago either.
So now we have emergency departments, and we have urgent care, and now we even have something called an outpatient emergency department or something like that, right? Where you can be an emergency department but not be attached to a hospital.
Yes. So we have a few within the state of Iowa. Iowa was probably one of the states that did not get impacted as greatly as, we'll say, Texas, that have a lot of what we call standalone EDs.
Mm-hmm. And so there are, in Des Moines, is there a standalone ED?
None in Des Moines.
None. Okay.
Yeah. So I think we have 2 in Iowa right now. I want to say 1 near Cedar Rapids, and I apologize, I can't remember the location of the second one.
So in Iowa, we've got the choice of an ED, which are attached to hospitals, and urgent care. How should a patient view when they go to one versus the other? What's the difference in the care that you get in an urgent care facility versus an emergency department? And how would you instruct patients to make a decision on which place to seek care?
So sometimes that's a difficult assessment for a lay person to make. When should I go versus not? The beauty of going to the urgent care is if it is something they're unable to manage, or something that they deem you need a higher level of care, they will refer you immediately to that location. So there's one piece of saying, if I go to the urgent care, I'm never going to be wrong. The second is, if you do have a life-threatening condition, as we know, time is of the essence. And so ensuring that if you feel it is something imminent, i.e. a heart attack, a stroke, a ruptured aneurysm, those are the conditions that are time sensitive, that we would say, don't waste time going to the urgent care and proceed directly to the emergency department. The other piece, and this is what always is confusing, is there may be certain urgent cares or walk-in clinics that may provide IV, but normally that's not the case. So typically, if you're perceiving that you're dehydrated and you're going to need replenishment of crystalloids or lactated ringers or whatever it may be, that you would proceed to the emergency department for that definitive care.
Okay. And what should everyone know about what to expect when you get to an emergency department, and maybe share a little bit about the challenges that we've gone through, that emergency departments have gone through, especially in COVID and the workforce shortages that has resulted in closing of hospital rooms and sort of the clogging up of emergency departments.
So this is really, we could talk all night about this topic per se, but unfortunately, as Dr. Demings alluded to, during the pandemic, we had a lot of individuals that left the workforce, whether that was for other jobs or roles within the healthcare sector, left healthcare altogether. And that is nearly every department, whether that was a physician, a nurse practitioner, a nurse, a respiratory therapist, CT technicians were impacted to some degree, even individuals that saw early retirement. Right, maybe they were at their point of that career in that 21 to 22 timeframe. We saw individuals that exited health systems. Unfortunately, when you lose that labor force, then it creates an issue with how many beds you can keep open from a safe perspective. So what does that then do to an individual that may be coming to the emergency department that's seeking care is that if you do require hospitalization, you may stay in the emergency department longer before you're admitted to an inpatient bed. Or there may be a determination of, can we manage this effectively as an outpatient, allow you to go home to manage that effectively as an outpatient. But back to your kind of underlying question, if you come into the emergency department, you may see a moderate number of individuals in the waiting room, and that shouldn't surprise you. And we're probably seeing that more pervasive even in our smaller locations within Iowa. And this isn't just an Iowa issue. This is across the country that we're seeing this. And we're talking to individuals in Ohio and New York and asking, what innovative ideas, things that they've been implementing to try to address some of the, what you described as clogging in the system or capacity issues that we're running into. Because even though we have seen some decrease in on that we were very reliant on during the pandemic, we've started to see a little bit of that transition back, individuals wanting to come back home. And so we have seen a reduction in travelers. It still hasn't been enough to occupy the open vacancy positions that we have in all these areas. And I don't foresee us getting back to where we were for several years, if not longer. And I think it's going to require us to change our care delivery. Some of you may have heard of virtual nursing, which is one of those elements that we've kind of implemented within Mercy One to try to combat that, which is using a nurse that's on a computer that helps alleviate the nurse that's at the bedside. So it's a complement to that nurse to help if that patient has questions, if a family member has questions. So helps address it so that nurse can then be alleviated to either get the medication or address another issue that may be occurring with another patient in that same area. So again, just trying to look at innovative care models to ensure that we're providing not only high quality, but safe care to our patients that we're managing. Because we also know those patients waiting in the emergency department to get to an inpatient bed, not only is that a negative experience, but it also potentially can delay therapies that are necessary.
What if someone is experiencing an issue? And so one common would be that they've had chemotherapy and now they have a fever and they've called their oncologist, and that's one of the warning signs because chemotherapy can suppress the white count and make patients much more susceptible to infections. Obviously, a hospital is not a good place to be if you're immunosuppressed because there's hospital infections. How should a patient weigh the factor of going to the hospital, and should there be calls ahead of time? And is it usually the case that the oncologist would call ahead to let the emergency department know that this is a patient coming in? We suspect that it might be neutropenic sepsis, just a low white count with infection. How do you see that interaction happening when we're dealing with side effects and or complications of somebody who has a known cancer diagnosis and is undergoing treatment where their side effects could require a trip to the ED or admission?
So we see that quite a bit, and we still do offer direct admission for those patients. So those that are on the cancer journey typically have a very strong rapport with their oncologist and the team. And typically there is that mutual understanding that regardless of time of day or situation, that there is a contact with a provider and that there is a provider available. And to your point, depending on the severity of those symptoms, depending on that chemo regimen, typically there may be even discussion of, hey, why don't you come in, let's draw some labs, let's see where you are, attempting to minimize their exposure risk. Because I think not only is the primary oncologist want to mitigate their risk, but also the patient isn't always that encouraged or desiring to go to the emergency department if they can avoid it. Obviously, understanding if they can't, they will. So I know very closely they'll tie into attempting to facilitate labs, and depending on those findings and the clinical condition of the patient, at times they'll call what we call the LINCS or Patient Logistics Center to try to facilitate a direct admission if, in fact, they've solidified that there is a neutropenic fever that's occurring that's going to require parenteral antibiotics and ongoing management. And they're typically very good about doing those. On the rare instances, and typically it's more the individual may be profoundly ill, maybe had some associated repetitive vomiting or diarrhea that caused some volume depletion, and now their sensorium is altered and they have the associated fever. Those are the times that they may have not had an opportunity to call the oncologist because the clinical condition has worsened, and those individuals will come into the emergency department. We typically, in those settings, will attempt to accommodate them immediately into a room to ensure that we have all the necessary equipment to address those needs. So again, trying to minimize their exposure to other individuals, in addition to minimize the exposure to those individuals that are in the emergency department as well.
What are some of the other conditions that cancer patients might experience that you see in the emergency department?
So typically when we think of cancer, I think the three things that usually are very prevalent are the associated fever, the intractable pain, either it's new pain or it's pain that now is no longer controlled, secondary to metastatic condition or other conditions. And then the third most common is usually shortness of breath that we'll see. And that can be a manifestation of an effusion that may have developed to a large pulmonary embolism, because we know those individuals with cancer are hypercoagulable, so they're at increased risk of developing those thrombotic events.
And how about dehydration? Is that something that you see?
So we will see that definitely on that spectrum as far as frequency goes. I think it's like 4th or 5th as far as common diagnosis that we'll see in the emergency department. But yes, definitely dehydration.
And you mentioned pain. Sometimes patients will not have a cancer diagnosis, but have severe pain, and they go to the emergency room, emergency department because of the pain. And you guys might be the first ones to look at a scan or an X-ray that may be pretty obvious at that point that this is metastatic cancer. Have you had to be the one in the emergency department to tell somebody that they likely have cancer?
Unfortunately, yes. I've cared for patients that either have had a cancer before and now have a recurrence and presented with pain. So typically, when you're thinking of red flags in the emergency department, that's one of the questions that you're asking is, do you have a history of malignancy? And if the answer is yes, a little sense in your mind goes, okay, we need to make sure that this isn't something more pathologic. And unfortunately, because of that, we've identified, new renal cancer or significant metastatic disease from a primary tumor somewhere else, lung cancers with metastasis that we've identified. And those can be very difficult conversations. And as you know, at times, depending on that patient's presentation, they may be by themselves, that there is no family with them. And, they're meeting me for a very short period of time that's popping in and out of that room. It's not really an environment that is conducive to developing a strong rapport in a short period of time. So you're attempting to share that information with them and be very careful with how you share that information as well. Because as we know, individuals will start closing their mind as far as what information you share and what next steps are. So that if they're going home in particular, that you may need to come back a couple times. You may need to make that request of, is there family or someone else I can contact to make sure they're also aware of the care plan as well.
And in general, not just cancer patients, but just in general, what are the most common reasons for individuals to show up in the emergency department?
Most common is typically abdominal pain. And undifferentiated abdominal pain, not necessarily appendicitis, Chest pain is up there as well. And again, non-specific chest pain, it could be something as simple as pleurisy or just a musculoskeletal issue. But as we know, we're very concerned about cardiac conditions. So individuals will come in for chest pain, and mental health or behavioral health issues have definitely increased in frequency. I do want to go back on kind of one of the questions, and I'm going to put my administrative hat on, is so as we know, Iowa is a rural state. And so sometimes individuals perceive administration doesn't have a lot of insight on what's happening in healthcare and how they can help the provider that's actually caring for patients. Across the country, we are in a deficit of physicians. So most updated would say by 2030, we're going to have nearly a deficit of 100,000 physicians across the country. And 100,000 physicians, about 40% of those are going to be in primary care. So as you talk about me making that primary diagnosis in the emergency department, if you can't get in to see a primary care provider, it becomes more challenging to see a primary care provider. You could potentially see how we could see those increases coming into the emergency department because access of care is compromised because of our inability to recruit primary care physicians into locations because that debt or that supply just isn't there to overcome that. So that's something that we are thinking about forward, is how do we increase the residencies that are in the state of Iowa? How do we keep the medical students that are graduating from DMU and University of Iowa within the state of Iowa so that we can increase that primary care base? And that has to be a focus. And that 100,000 number is actually better than the projection that AAMC came out with about 2 years ago. They were projecting about 130, 140,000 deficit. And their perception is that because we have increased number of residencies, a few medical schools have opened, that's why we're starting to see that impact. So we know that if we can continue to focus there, that we can address this gap to some degree to minimize, again, that primary diagnosis occurring in the emergency department. Not that I don't want to have a job, but I also do believe from a patient care perspective, those diagnoses being managed proactively are much better than by the time they get to the emergency department.
Yeah, the emergency department isn't a great place for vaccination, prevention care, screening for cancer in patients who don't have symptoms. Not a good place to do that.
Exactly.
Would you say that the increase in training programs for nurse practitioners and PAs, so now we lump it all together, doctors, nurse practitioners, PAs, we call them providers, and that they're taking up some of the slack in primary care?
Yeah, absolutely. And then we're seeing that they are kind of filling the gap. And especially when we look within Iowa, that is a growing number of providers that are filling those gaps for us as physicians. Again, I go back to that 2021, 2022 individuals leaving, retiring early, decreasing their practice. And fortunately, we did have some NPs that have come, but we also know we still need the physician support to be there. So they'll provide one angle of support that we definitely need that will help, but we still need those physicians that are out there that are able to assist as well.
So back to the discussion about some of the chief complaints, why people go to an emergency department. Where does trauma fit in? Is that like in the top 5? If you include all trauma, major trauma, but also
minor,
slice my finger cutting an avocado or something like that.
Yeah, I would definitely say your musculoskeletal / minor traumatic injuries are definitely up there. If we were to categorize them, I would definitely put them in the top 10 as far as reasons to come to the emergency department. Now, at times, individuals are going to the urgent care, and you're reminding me of the story of this young kid I took care of, 17 years old, and he and his buddies, he sustains a laceration in his hand, and his buddy says, "Hey, I can fix that." And so he takes a hot iron and he's going to sear it together. So obviously the kid screams and doesn't tolerate it, but excoriates and burns.
Yeah. So now you've got
second / third degree burns,
a laceration and a burn. Okay.
So then he's like, "Well, you know what? That didn't work, but I got this fish hook. So I'm going to take the fish hook." And as we know, fish hooks aren't really designed to be taken through the skin kind of repetitively. So now this kid comes in.
Oh my God.
This kid comes in with this second / third degree burn to his hand. It just looks awful. And he has this hook kind of stuck through it, and he waited several hours to come in. And yeah,
Okay.
so those are the types of injuries at times that we deal with.
Yeah. So I'm not going to take you down a path of weird things. No, we're not going to go there unless there's questions. Back to what our audience should know. What do you think are some things that they should know that might help them get like, how do you get through the triage? Is it can you just say chest pain and that gets you a free ticket to a room? Or what do we need to know?
So our nurses are very well trained, and they will take every complaint at face value and make a determination of how critically ill you are based off of not just your chief complaint, but your vital signs and how you potentially
Blood
are presenting.
pressure, pulse, temperature.
Exactly.
Yeah.
And so what I would say is, regardless of what emergency department you enter, that there potentially could be a wait time. If you are waiting and you feel that your clinical condition has changed, you're getting worse, maybe, again, depending on what you presented with, your symptoms have changed, that you always would let the triage nurse know conditions worse or these symptoms have changed so that they can do a reevaluation, because there are at times when conditions can progress. Maybe you presented, you didn't have a fever, now you have a fever in a short period of time to a longer period of time, depending on how long you are in the emergency department. That being said, they do a fantastic job of if they see there are red flags or concerning symptoms that someone presents with, ensuring that we create capacity to evaluate those patients in a timely manner. But to your point, would still anticipate there are delays, anticipate that your nurse is very well experienced. Unfortunately, sometimes what we hear is, let's assume you walk into the emergency department, or I should say the waiting room, and you see 3 or 4 people. Know that there are individuals that are coming in through the ambulance bays, or individuals that are coming in through the helicopter that you may not see coming in through the triage desk, but obviously are impacting the flow of the emergency department as well. Right. So not seen, and they will typically take precedence. Again, if you can imagine, usually individuals that are coming in through the ambulance are typically a sicker patient population. We will also triage those individuals to make sure, is this someone that can safely wait to be evaluated? Because there are certain times that it may just be where they were, that they had to call an ambulance for service. Not that they don't need the emergency department care, but it can be something that's delayed. Right. So we'll try to triage those as well.
But it's not like a Starbucks where you just get in line and you get served.
And here's your number, and this is your number that's going to be.
So you get served based on the seriousness of the problem.
Correct.
Yeah.
And a lot of emergency departments across the country have put what they term a PIT, or a provider in triage. So at times, depending on the time of day, they will attempt to have a nurse practitioner or a physician do just kind of a high level screening examination to make sure that if there are things that we can get started while you're in the waiting room, whether it be lab or x-ray, i.e. you think you broke your finger, maybe it's something very simple, we can get that x-ray started. So as you're waiting, you're getting the appropriate care. So then when a bed or a provider is available, they can reevaluate your imaging and make a determination if you need a cast or if you can go home safely.
So in the 17 years that you've been an emergency medicine physician, what positive changes have you seen in terms of treatments that make a difference? And I'm thinking of maybe clot retrievals from cerebral blood vessels, or injecting clot busting chemicals into the pulmonary blood vessels, or faster access to coronary procedures. What are...
I think all those things you mentioned have definitely evolved. So when I started emergency medicine training, there really wasn't any therapy for stroke. So seeing the evolution of thrombolytic therapy, seeing kind of some improvements, but then the game changer was mechanical thrombectomy. Once you're able to identify those individuals that qualify for essentially clot extraction of a certain artery within the brain, and to see them go from a profound right-sided hemiparesis, i.e. can't move their arm or leg and maybe their face is drooped, and to have complete resolution within a few minutes of this procedure. I mean, that has been a game changer when it comes to stroke care. And being at a facility.
And maybe explain a little bit what that consists of. A mechanical thrombectomy. Someone comes in with stroke symptoms. They get imaging of the head, and you see that this deficit is being caused by a clot that's in a major artery of the brain.
Correct. Everything that you just stated. And this, again, is a time-sensitive condition. The sooner you get that appropriate imaging and appropriate intervention, the higher likelihood that your outcome is going to be optimized. And so you get a CT scan first, so non-contrast CT, to ensure there's not a hemorrhage. Assuming there's not a hemorrhage, then we do the advanced imaging, which is looking at those arteries that Dr. Deming alluded to see if there's a clot in one of those vessels. Having a clot itself doesn't necessarily mean that you qualify. It's having a clot in certain large vessels that can be retrieved. Because if you can imagine, anytime you're sticking a device into an artery, especially in the brain, you want to make sure that it's large enough to be able to extract a clot, because there is a risk of bleeding from those interventions that are being done. So they have to be in specific categories, specific impact to the body. So let's assume you come in and you have a little bit of numbness in your right hand, and that is your symptom associated with the stroke. Probably not going to go and get a mechanical thrombectomy done, because your symptoms are very mild, even though it could still be a stroke. So for a lay person, the easiest is to say stroke care. If you are having deficits, be evaluated immediately, and then we can make that determination if, in fact, we need that advanced imaging to get there. To your point, that to me has been one of the biggest changes in medicine that I've seen. Have we seen it obviously with blood clot extraction? We've seen individuals with large clot burden. So we say if they have high clot burden, that means it's just a big thrombus that's sitting in the lungs. Seeing these individuals go through, again, extraction of the clot burden, and their morbidity or how they live after these events has been profoundly impacted positively as well. Where some of these individuals may have left on oxygen or limited on what their conditioning is, be able to leave the hospital with no supplemental oxygen and be highly functional. It's been extremely profound.
And how about the care in the emergency department related to coronary artery disease?
Sorry.
No.
Yeah. Okay. Yeah. That to me, I mean, and especially again, being part of Mercy One, being part of Iowa Heart, and seeing those teams come in and be able to identify if an individual needs emergent cardiac intervention, and going in and doing those clot retrievals or coronary intervention with stenting place, that has been phenomenal, and they've been doing that for quite some time. Now, what we've seen, obviously, with advancements, especially in our electrophysiology and other areas with TAVR, where individuals used to have open heart surgery for valves. That just was it. And about, what would you say, maybe 8-10 years ago, these transaortic valve replacements, so you don't have to open up somebody's chest. You can replace the valve through
the blood vessel.
Through the vessel, and have that done, and an individual be home within 48 hours versus 10 days after surgery with a large scar. It's been significantly, it's again, seeing the individuals leave the hospital with no significant sequelae, recovering at home and doing great within 48 hours of a procedure that historically would be 2 weeks, and you have a large scar and a significant amount of pain, has been a profound impact to our communities.
We're going to open up to questions. So we've got a live studio audience. We also have individuals watching us live streaming. If you're watching us live streaming, please put the question in the comments section. And let's start with, where's the mic? Rob Boone, you get to go first.
This is about cancer patients. Someone's going through treatment. They're running a fever. It's not high grade. Or other symptoms they're having. Does Mercy have a nurse, oncology nurse on call that they can call before going to the emergency department?
So unfortunately, we don't have, historically, we used to have the Mercy nurse. So someone could call regardless of their condition and make an inquiry. Unfortunately, we don't have that service anymore, but that's where we really have partnered with our independent and employed providers to be able to provide that service directly to their patients and get that guidance that they need. So
Yeah.
24/7, you can call your primary care provider or your primary oncologist to ask the specific question that you outlined, and make that determination together. Is this something I need to go to the emergency department for? Is this something I can wait and potentially come into the office tomorrow morning to be seen, and have that discussion kind of together?
Yeah, and I will amplify that the oncology offices answer the phone 24/7 and do give the guidance, and they also have a clinic on Saturday and Sundays. So you can, if you're dehydrated, you can get IVs. If you're having some symptoms and need to be evaluated, they actually do that in the cancer center. So it helps unnecessary trips to the emergency department. And so those are questions that the hospital doesn't answer, but the cancer doctors have their phones answered 24/7 and give guidance on those for their patients that are actively undergoing treatment. Angelina.
Yeah, I enjoy all the information, but you got me at that story, and I need to know the ending. Did that poor young man, were you able to save his hand?
So we were able to save his hand. So he did have we actually had one of our hand specialists come in to evaluate him, because he did need to get taken to the operating room and cleaned out to make sure that wound could heal effectively. But I will say he left with a larger wound than the wound if he would have just came in to have it sewn up originally. So unfortunately, probably a larger scar, but hopefully a lesson learned, if nothing else.
Is he still friends with that buddy?
They were both laughing as
Okay.
we said
Okay.
what was going to happen. So I think they're pretty
Was
tight.
there alcohol involved?
Unfortunately, there had been, and I
Yes.
think they waited to some degree of sobriety to come in
Okay.
together. So
Fred.
I wanted to share that an experience of somebody with cancer. My wife was just starting her treatment for cancer, and she had a severe reaction, and so severe that she couldn't even roll over in bed, totally immobile. And then when I tried to help her, I recognized that her body was started with her legs and then primarily a rash everywhere. And so I called, you mentioned oncology on call. So I called oncology, and of course they said, call the ambulance and go to the emergency room. And we did. And of course it's fortunate in doing that, but also because the oncology or doctor was right there at downtown Mercy. But it took, they didn't really know. They knew it was a reaction, or they thought it was a reaction, but they stabilized her and they admitted her to the hospital. And this was before COVID, so she got a room, which was good. And so it was really quite an experience, but it took them quite a while to figure out what it was. It wasn't until they had restarted one of the meds, and immediately there was a reaction, a slight reaction, that they knew what they just didn't know exactly what had caused that.
So it was an allergic reaction to one of the
Allergic
chemotherapy
reaction to
drugs.
one of the meds that she was getting, and it was severe. And so Sandy was in a situation where the emergency room was crucial because she never regained mobility totally. It was a really strange thing, and the oncologist couldn't understand why. So there was this whole notion that something else was going on, which eventually led to falls and led to other emergency room visits that were directly or not kind of indirectly connected to her cancer, because the treatment for the cancer seemed to bring out symptoms that later were diagnosed as Parkinson's disease. And so, it was really the emergency room is, you're right, is when it's needed, you want to be there.
Yeah.
But I thought I'd mention, because the reaction, you hadn't mentioned that, one of the things possible, you're taking a lot of new meds. Of course they ask, are you allergic to anything? penicillin or any, but how do you know when you're starting to take new meds? And
So-
it was a really severe reaction.
Allergic reactions, is that one of the common issues you deal with in the emergency department?
I wouldn't say common, but it is a frequent occurrence, and there are different types, as we know. There are anaphylactoid and anaphylaxis, and for those just from kind of education perspective, there are certain medications, or we'll say contrast, that you don't need to be exposed to it before you will just have a reaction. And there are others that you've been exposed to it once, your body has developed antibodies, and now when you have the second, you have a pretty significant hypersensitivity reaction. So there are different types where you don't have to have the exposure before and have a pretty significant response. In that situation, it sounds like maybe she'd been taking the medication for a period of time, which probably
Not very long.
led to a little bit of, well, is it this? So
And she
again,
was taking some over-the-counter things at the same
Time.
time they prescribed, so they weren't sure. She had to stop everything and then kind of restart incrementally to see what it was. I don't know how you check for that kind of reaction. You can't determine it through the blood or anything.
and I would say about, if I'm not mistaken, it's a little over 80% of hypersensitivity reactions, we will never know what precipitated them. So unfortunately, a greater propensity of time, we won't know what the etiology was. And to your point, some of these can be pretty severe, where we actually encourage individuals to carry an epinephrine pen with them in case that this situation were to arise, because they're unable to identify it. They were stung by a bee, or again, a new detergent or something that they introduced to their body that they were not aware of, but the response was so significant that we may make a recommendation like, going forward, you should carry one of these just in case.
And I would
Ca-
say that particular, because I was really a mess. But, the emergency room assured that, there was some calming effect to it that was, that particular incident that sticks in my mind,
Well, I appreciate you sharing that,
Great.
Rick. Thank you.
Kevin?
Well, what percentage of ED visits do you think are related to just bad decisions made while using alcohol or drugs?
That would be completely a guesstimate.
Yeah.
Do I believe that they're contributing? I think there's a percentage. Now, one could say, is it related to bad time, right? So, i.e., an individual who may be a smoker that develops lung cancer. Is it a bad decision because they were smoking for a period of time, or and I'm sure Dick is much more familiar with this. There was a recent Iowa study that was published in 2024 discussing the correlation of alcohol to this increasing number of cancers that we've seen within the state of Iowa. So obviously saying that there is a correlation with alcohol consumption in general that may be playing into some of the new cancer diagnosis that we're seeing.
But in terms of like individuals who are under the influence of alcohol, here, hold my beer, watch this sort of thing. I mean, you must keep statistics on that, or on
Those are still difficult. So again,
Okay.
you've identified one group of individuals that it's pretty obvious, right? They
Right.
had a traumatic injury, they were consuming alcohol. You can
Mhm.
correlate those.
Mhm.
I think we see, as I stated before, increasing number of individuals with mental health conditions that sometimes that makes
Yeah.
it harder to
Yeah.
know is their mental health condition contributing to their substance misuse, or their substance misuse contributing to their current presentation. And those are a little
Gotcha.
harder to know.
So, under what circumstances would you, as an emergency medicine physician, order a blood alcohol level or a toxicology screening for someone who has trauma, and that you suspect, based on their demeanor, odor, all of the other things, that there's substance that contributed to this? When is it necessary for you to know? When do you not order it because you're concerned you might put them in legal jeopardy? When is it mandatory that you do a toxicology or alcohol screen?
So typically, if they are a minor, there's a little bit more mandatory nature associated with kind of checking, because obviously from a parental perspective, is there some compromise that may have been occurring there. So speaking strictly from adult perspective, it really goes back to the change of management. Am this person going to be admitted to the hospital, and will knowing that answer results in different treatment? To know isn't typically a reason that you're going to.
What about motor
the
vehicle
test.
accidents where there's almost always the possibility of
So
lawsuits that happen afterwards?
historically, again, the hospital is not a legal authority. And if we draw a blood alcohol level, because again, we needed to do or an assessment, maybe individual slurring of speech, and you're attempting to differentiate, is there an acute stroke going on, or is this alcohol related? Typically that is dismissed. That is not considered something that can be used within the court of law. Typically there has to be, again, by nature, if the police were to come in and have a blood alcohol level, they historically had the medical examiner come in, draw, and that would be sent to the state lab for review, and that would be part of that case. There have been some instances now with the medical examiners being a little bit challenged with the number of individuals that they have within their workforce to partner with the hospitals only to draw. They draw, police will then take custody of it and then send it again to the state lab. So it's not part of our medical record. The results are all controlled and governed by the state, and they are making that warrant to say we need this test now. But typically we are not judge and jury to attempt to determine or incriminate an individual from it. We may get it. Typically part of our trauma protocol is getting a blood alcohol level to ensure that's not contributing to an incident or something else, but it's really more from is it affecting our ability to get an adequate assessment of the patient? Someone may say, I have no pain. Their blood alcohol level is, X. And you may say, okay, this individual is going to need more frequent reevaluations to ensure that as they become more sober, that their clinical examination isn't changing and we need to image other areas.
Yeah, a question that'll be difficult to answer in the amount of time that we have remaining, but mass shootings. A lot of people will tell you that it's not a matter of if, it's a matter of when. Are you getting preparedness for that? Do you get special training for that? Are your folks ready for that?
I don't necessarily know one can confidently say you are 100% ready to manage a situation like that until it happens. I think the Perry incident kind of opened our eyes to it can happen here. And I think before and even after that, we continue to evaluate our processes that we have in place to address those situations when they arise. You would be surprised the number of individuals within our own medical staff that are willing to help in those events, and how quickly we can mobilize OR resources between the two metro facilities to manage situations like that.
And we're going to end it at that. We're going to have you back because there's lots more questions. But Dr. Hinio Carrion has been our guest, an emergency medicine physician and the chief medical executive for Mercy One.
Fantastic. Well, thank you, Dick.
Thanks,
Appreciate
Hinio.
it.
Thanks, everyone, for attending. If you know someone that would benefit by watching this program, it will be available on demand beginning tomorrow on the Above and Beyond Cancer YouTube channel and the Mercy One Cancer Center website. I hope you'll join us again next week. Thanks, everyone.
Thank you, sir. I appreciate it.
Thank you.
I told your audience here that I would